he could not, very faint movements of his toes. And on examination, it was a cold limb. Capillary refilling time was more than 3 seconds. Toe movements were impaired. Sensation was impaired, and the saturation was not detected with no regular waveform. Now, sometimes this is misdiagnosed for a stroke, but the difference between a acute ischemic limb is it's not only the weakness, there's a severe pain in the. So we have a window of opportunity, and he was found to have atrial fibrillation. So irregular pulses. So probably, so clinical diagnosis of atrial fibrillation with acute embolus was done, but usually we lose the femoral pulse also, but in this case only the popliteal and pedal pulse were absent. So because this was the diagnosis, we immediately took him into theater, and he underwent emergency left femoral embolectomy, and that alone is not enough. Once you make this clinical diagnosis of acute ischemia, we need to give them heparin that will give unfractionated heparin, about 5,000 units, and then if you are in a hospital setting, infusion for that, anticoagulation. So, and in this particular patient, because it was a late presenter, and about 4 hours later, and there was a swelling in his calf, we also did a fasciotomy, but the limbs were, the muscle compartments were viable. So the acute ischemia is a condition which we should not miss. So they present with no history of pain whatsoever, and sudden onset severe pain with paralysis, or sometimes to less degree pain with paralysis. They can limp and walk, but this is an acute onset limp and acute onset paresthesia that they may get. Sometimes you get this on a background of history of claudication in the past. So then we should think it is an acute on chronic. But however, if you don't attend to it immediately, there's a large there's a chance that we may lose the limb. The second female, the patient is a 60-year-old female, presented with fever for 3 days. And she is a patient on with diabetes and on insulin, and she has noted slightly red second toe 2 days back. And now she started getting chills and poor glycemic control. And she did not have significant pain. Now, the problem in some diabetics is because of the neuropathy, till very late, they do not get pain. However, discoloration, red, purple, black, should not be ignored in a diabetic patient, because this is her picture 2 days later. And now here you can see there is a gangrene of the second toe, but it is not dry gangrene. Around that you can see it spreading. Now, this, when we examine the pulse of this lady, she had also absent pedal pulses. So this particular condition, and with the white cell counts are very high, and she had, so now we have a situation where we have a ischemic septic system in this leg. Now, if this is unchecked, and antibiotics alone is not enough, this warrants IV antibiotics. So this particular patient, if present, requires to be in a hospital with IV antibiotics. But if you do not have source control, only antibiotics is not going to help. So and sometimes if the patient is far, and if you're going, because lack of pedal pulses, the revascularization is urgent but not an emergency. But ischemic septic, the message here is a ischemic septic system is an emergency. So we should convert it quickly as possible to a non-septic ischemic system. So the revascularization is urgent but not an emergency. You don't have to do it within 48 hours. So this patient requires debridement. In her case, she lost the second and the third toes event during the wound toilet. So what they require is here we defer the vascular part, but we must control the sepsis. So we started on empirical antibiotics, and depending on institution to institution, that will change. And she had urgent wound debridement and tissue culture sent, and then we can change into specific antibiotics. And eventually she ended up, once we control the sepsis, then we get on, or once we have got source control of the sepsis, then we went and revascularized her. And however, now had she noticed a color, now patients like this, a simple footwear, looking after the feet, we could have easily prevented this condition, this emergency from coming. And if she checks the feet, she would have noticed a slight color change before it's black, when it's red. So somebody needs to check feet like this. Now here we have another scenario. There's a 33-year-old male following a motorcycle accident. He had sustained a compound fracture of the left tibia and fibula, gustilo 1, and basically, but his pain, the difference in his pain was his pain usually in a fracture and all, the most amount of pain, the maximum pain is during that, when immediately after the event, but later it gets better with splinting and immobility. However, in this, or when you put a plus, in this particular patient, the pain started getting worse with time. And 3 hours after the injury, the pain is worse than that. So now, and this is the picture of this patient. Now, when you have a situation where the pain is increasing with time, we need to suspect whether we are dealing with something else other than this isolated fracture, because the fracture has happened and now the increase in pain is a worry. Whether there is a damage to the arteries, and whether there is compartment syndrome developing. Now, when you look at this fracture, when you look at this fracture, in this part, there's 3 arteries. Highly unlikely for all 3 arteries to be damaged at the same time. If that is the case, then there is such. I seem to be having a problem with the. So his pulses were palpable, so there was no acute injury to the arteries. But passive movements of his toes cause pain in the calf. So that is a cardinal feature of compartment syndrome. So in this particular patient, because of the injury and the probable hematoma and swelling inside closed compartments, he is developing a compartment syndrome. So now, and another feature of this is they will have paresthesia between the first web space. That's one of the first signs to come. If not, it's a very simple thing, because even if you have splinted the patient, you have access to the toes, dorsiflex and plantarflex the toes, and you find pain. So once you diagnose compartment syndrome, we lose the leg because of muscle necrosis. So this person underwent a emergency 4-compartment fasciotomy for compartment syndrome, and the limb was salvaged. Now, in the same instance, the same message is any leg that has swelling and with continuously increasing pain following, it can be following a snake bite or following any surgical procedures done there, or even following rigorous exercises, sudden you play rugby or sudden pain in the calf and slowly the pain increasing. Any cause of fluid collection within compartments may cause that. And another cause of thingy, we should never forget this, the external full plaster cast. So sometimes the patient presents very early, and then we put a full plaster of Paris POP all round. Then what happens is because this patient has come early, we have put it there, and then the swelling starts develop. And here we can have external compartment syndrome. This is where the leg is trying to swell within this closed compartment of the plaster of Paris. But here, another thing is the patient starts developing pain, gets worse and worse with time. So whether to see whether the plaster is too tight, you may try to put your little finger from the top and bottom, but these are very crude tests. But the simplest test to see whether the person is getting compartment syndrome within this is to dorsiflex and plantar flex the toes, and you will feel the pain. If it's excruciating pain in the calf area, you know that. So here the therapy is a simple therapy. You don't have to do fasciotomy. All you have to do is divide the full length, full depth division by weaving of the plaster. So that's why sometimes the back slab for the first 48 hours and completion of the plaster after 48 hours sometimes is safer if you cannot monitor the patient. So this is for compartment syndrome. So then we have another case scenario of a 68-year-old female diabetic patient noted redness over the foot first two days ago and painful leg. She had been getting treatment for cellulitis. So now this, even though it's not strictly vascular, because this presents to a lot of vascular surgery, I thought I'll just for completeness sake tell this also, because this is also a surgical emergency. The difference here is the leg was blistering, and I put two images, and there are areas of necrosis of the skin. So the left photo, you will see there is areas of white. So that is also dead skin. Or on this side, it's a black onto the medial aspect of the foot. So the dead skin. On the other side, you can see discoloration and blister. The other photo. Now, this is not cellulitis. It's something worse. It is necrotizing fasciitis. It is actually in a patient, and it is in a ischemic limb. It can become devastating, even in a non-ischemic limb. So this requires thorough debridement. And antibiotics, and this cannot be managed with antibiotics alone. We need to debride. So extensive emergency wound debridement was done, and usually they need the second debridement 48 hours later, and they may have, they are very sick. This particular patient developed acute kidney injury, creatinine went up and recovered, but the limb was saved. But some of these patients have such large wounds and loss of skin, we need to skin graft, but that is a secondary problem. Then another patient, a 52-year-old male, he's obese, he had recent onset ankle pain and was in bed for a few days. And his right leg was swollen and had a mild pain for about 3 days following his bed rest period. So when you have this type of patient who is not ambulant, having leg swelling with or without pain, always suspect deep vein thrombosis. This is a emergency, because if you do not treat, some of these minority of this patient will progress to propagation of this clot, and another minority with a pulmonary embolism, and another segment of the people who the patients who embolize will even can die. So this is the swelling. So once you suspect DVT, it doesn't matter even if it's not DVT. If you suspect DVT, even sometimes if you have access to a duplex scanner or investigation, immediately you can do that. Otherwise, the best thing is, till you exclude the diagnosis, you need to anticoagulate this patient, give treatment dose. So you can give heparin, unfractionated heparin, or low molecular weight heparin. That's very easy. Enoxaparin, body weight, twice a day therapy is good enough for the initially. So you give the first dose and then go on to investigate. So if you can, as a screening blood test, if you wish, you can do D dimers, and if the D dimers are normal, you do not need to to proceed further. However, if you have a duplex scan, you can do the duplex. And any popliteal or femoral or iliac DVT has to be treated. So in any post-surgical patients in the ICU, any swelling you notice, especially with unilateral, but remember you can get bilateral, please consider the diagnosis of deep vein thrombosis. So because this can be treated, but if it's a post-surgical patient, especially neurosurgical patients, there are other options which I don't want to go. For me here, it's just to give you overview. We can give anticoagulate initially with low, and right now we have the oral medication which is very effective against this. So you do not have, you have rivaroxaban 50 milligrams twice a day. But then, or if they cannot afford or we do not have it, we can convert warfarin later. But the initial diagnosis and prompt treatment is essential in this. And elevation of the foot limb and stocking, if the pedal pulses are there, is the initial treatment you have to institute. But it's a myth to say do not walk. These patients should walk. Even if you diagnose DVT, walking does not increase there is no evidence to show that it increases but in fact it is better to stop the propagation of clot. So these are the 5 different aspects of vascular emergencies which I thought of 10. This is a started anticoagulation, and there is another condition I want to do. If a patient, especially old one, I not put a slide on that. If a patient comes with backache, sweating, pale, think of a ruptured aneurysm. Always keep that in your diagnosis. If the patient has suddenly collapsed or the pain, the abdomen tense, it's always good to, especially if the patient has fainted or has features of severe backache, or feel the abdomen to see whether you can feel a pulsatile mass. So that can be a impending rupture or a ruptured AAA which is contained. So that is a life-saving diagnosis that you can make, which the patient requires to be admitted to the closest hospital. Thank you.
Thanks, Dr. Rashni Kasim, for excellent presentation of the management of surgical emergency on vascular aspects. You have discussed about the management of the surgical emergency of the limbs as well as the abdominal pain due to the ruptured or leaking aneurysm. This is a time for question and answer. Can anyone, any questions, please? Dr. Malik, sorry, Rashni Kasim, can I ask one question?
Yes.
So in case if, there are the patients who are being treated with benzodiazepine for prophylactic antibiotic, sometimes if it is accidentally injected into the artery of the lower limb, right? And how do you manage? Suppose if the peripheral pulses are being felt.
You suspect that you are given a intraarterial injection.
Yes, of benzodiazepine, but on clinical examinations, the peripheral pulses are felt.
So the patient will have excruciating pain in the leg, and the patient may present with acute ischemia. But then, if you have any suspicion like that, you should not discharge. And then you need to hydrate the patient a lot. Keep monitoring the leg. Usually what happens is when you give an injection like that, there will be a severe pain, acute pain, which not in the site of the injection, but distally, going right up to the leg, and the vessel is going to spasm. So that's why injection. So there is no specific therapy. Then what we do is, if usually we fail most of the time because we have lost access to that artery because that goes into spasm. So, but we can try to do thrombectomize, but this keeps thrombosing. But it's a bad thing if you give penicillin. However, if you suspect such a thing, we have to only supportive and fasciotomy and things like that. And you can give lytic agents to lyse the clot, but generally the outcomes are bad. But if you have inadvertently got into the because this is you're talking about benzodiazepine, we are giving IM, But we are much more lucky if we have a cannula in place and a drug is being given in intra-arterial. The first thing to remember is do not remove the cannula, because that has, you have access to that artery through this same cannula. So don't remove the cannula, leave it in the this thing. This will be the way you treat with heparin and lytic agents to access that vessel.
Thank you, Singh. Any more questions from the audience, please? So in the absence of questions, we will move on to the next presentation. Will be done by Dr. Malik Samarasinha. He is a senior lecturer, honorary consultant, pediatric surgeon. He is working in the Department of Surgery, Faculty of Medicine. He will discuss about the management of surgical emergency in the children. Dr. Malik Samarasinha, is over to you.
Thank you, Mr. Chairman. I hope I am coming through. My voice is coming through.
Yes, Malik.
Yeah.
Thank you. Good. Thank you again, Mr. Chairman, and thank you, President and Council of the Sri Lanka Medical Association, for inviting me to speak today. My topic will be acute abdominal pain in children. Is it surgical? Now, I'm trying to get my slide to move. Okay. Okay, a little hiccup, sorry. Abdominal pain is a common symptom in children, accounting for around 1 in 10 visits to primary care. The vast majority of these visits are due to non-surgical causes of abdominal pain, which are often self-limiting and due to non-serious conditions. However, around 2% of cases with acute abdominal pain coming to a primary care setting are due to causes which will require surgical intervention. Surgical causes of acute abdominal pain are much more common, being around 10 to 30% when one looks at emergency department visit. It goes without saying that it is of utmost importance to diagnose these surgical cases of abdominal pain early in order to prevent avoidable morbidity and even mortality. This slide lists some of the most common conditions that presented with acute abdominal pain to an emergency department. Surgical causes accounted for around 4.6% and were the 6th most common, and they were outnumbered by conditions highlighted in yellow, such as upper respiratory tract infections and otitis media, pharyngitis and sinusitis, which are probably the most common, about 1/4 of admissions, abdominal pain with unknown etiology, gastroenteritis, constipation, and urinary tract infections. So these were the top 5 causes of acute abdominal pain in this study, which reflected emergency department presentations. And the top 4 or the top 5 are all non-surgical causes. Now, this slide demonstrates some of the spectrum of conditions that may present with acute abdominal pain. I apologize that it's a rather crowded slide. However, as mentioned earlier, the vast majority of cases are medical causes, while the surgical causes tend to be confined to the gastrointestinal tract, hepatobiliary pancreatic system, spleen, and the genitourinary tract. The spectrum of systems that could be involved in diseases which will require medical management is very wide and even extends to cardiac causes, pulmonary causes like pneumonias, Hematological causes like sickle cell crisis, hemolytic uremic syndromes, henox-online purpura, metabolic causes like diabetic ketoacidosis, neurological, toxins, drugs, etc. So the causes are extremely wide, but in this presentation, I will be attending to the surgical causes, and the main ones are highlighted in yellow in this slide. Now, the spectrum of surgical diseases causing acute abdominal pain has a clear age-related pattern. Incarcerated inguinal hernia and interception account for around close to 90% of cases under 1 year of age in this published study, and around 2/3 of cases were due to acute appendicitis in those over 1 year of age. Now, this percentage will be even higher if one considers the diagnosis in the pre and post-adolescent age group. The causes of abdominal pain in relation to age is again demonstrated in this slide, in which I have circled the surgical causes and highlighted the more common and important diagnosis. So in the clinical setting, it helps for us to think of common diagnoses which are present more often in certain age groups, and also to think in terms of surgical versus non-surgical as an initial screening or triage kind of procedure, and also to try to identify the causes which need urgent or immediate surgical intervention or care, or even medical intervention for that matter, and the causes that could have less emergent treatment requirements. So one can see here that in the young infants, 0 to 6 months of age, the two common causes which I mentioned earlier, incarcerated inguinal hernia and interception, are there. And to this, I have added malrotation and volvulus, which is not as common, but it is something that one has to have a high index of suspicion, because if it is missed, it can end up in an absolute disaster where the whole midgut can be gangrenous, which is not compatible with life. In the older children, in the toddler age group, we see diagnosis like appendicitis coming up. Malrotation could still occur, interception could still occur. But when it's the school-going age, we see the main diagnosis, the surgical diagnosis, are appendicitis, complicated acute cholecystitis sometimes, not that common, but very important to remember gonadal pathologies in the male, testicular torsion, and in the female, ovarian disease like emergencies like ovarian torsion or torsion of an ovarian cyst, and even think of ectopic pregnancies in the adolescent and post-adolescent girls, although luckily it's not that common, but if we don't think of it, we will tend to miss it. Then again, at this age, we see more of small bowel obstructions, usually due to adhesions, and often it is a past history of an appendicectomy which is responsible for these adhesions. Obstructed inguinal hernia also are seen at this age, and so are some other conditions. So this demonstrates the spectrum and the value in evaluating these patients with a knowledge of the common causes at given ages, and again try to triage and get the try to identify the surgical causes, and of them also the urgent causes early. So in evaluating children with acute abdominal pain, it is important to be able to identify the surgical patients, as I mentioned, at an early stage. And this can be done to a good extent by taking an insightful history and physical examination, and at times supplemented by some basic investigations such as blood investigations and sometimes even imaging studies. So you can see in the history, if the pain is acute in onset, severe pain, and it is more localized than more general and midline pain, and the pain is in increasing intensity, it tends to be more a surgical cause, such as appendicitis, for example. And in the surgical causes, generally the pain precedes any vomiting, whereas in conditions where the vomiting precedes the pain, it's more likely to be medical, such as, for example, the gastroenteritis. Bilious vomiting is always to be considered with a lot of suspicion, and it is almost always due to a surgical cause, intestinal obstruction or a paralytic ileus due to peritonitis, for example. Hematochezia or blood in the stool is also an important sign to be sensitive to. Here, there are medical diseases like the gastroenteritis, the dysenteric illnesses, and sometimes acute inflammatory bowel diseases, which might produce ER bleeding. But there are important surgical diagnoses such as interception, bleeding from a Meckel's diverticulum, or the presence of ischemic gut that may manifest with hematochezia. So that sign or symptom should also be looked on with suspicion for a possible surgical pathology. Previous abdominal surgery also is, if there's evidence, that also points in the direction that it could be surgical in terms of adhesions and intestinal obstruction. In the physical examination, if the patient is more ill-looking, lethargic, with abdominal distension, then one should think of a surgical pathology. And the tenderness generally in these patients with pain tends to be more localized, with peritoneal signs such as guarding, rigidity, and rebound tenderness, which all suggest the possibility or high possibility of a surgical cause. Whereas in the more medical causes, the tenderness tends to be more diffuse with no rigidity or rebound tenderness. So in this way, these can be again supplemented by certain basic tests like a complete blood count, serum electrolytes, liver function tests, serum amylase and lipase, depending on where the site of pain is. And if you're thinking of something like pancreatitis, where the pain is more epigastric, and even urine analysis. And in the adolescent female, think of urinary HCG level assessment if you think it is required. And then, of course, imaging studies, provided that the facilities and the time is there. But I think if a surgical pathology is suspected, it's good to get an early surgical consult before one, or without wasting time in doing too many investigations. Here again are highlighted some important clinical features, this time in alphabetical order, that point to a surgical abdomen. Absent bowel sounds, bilious vomiting, bloody diarrhea, elevated temperature more than 38 centigrade, rebound tenderness, rigidity, that is involuntary guarding, and voluntary guarding. So these are all features, again, which are highly suspicious of a surgical pathology. So when confronted with a sick child with a possible acute surgical abdomen, it is important to attend to these aspects that I have highlighted in this slide. So one has to do a quick diagnostic workup for the sick child. One has to pay attention to fluid and electrolyte deficits, if any, and intravenous fluid therapy may be required in these children. Appropriate pain relief is important. And in cases of severe abdominal pain, one should not hold back on opiates, and they do not delay or interfere with diagnosis, as what was the thinking some time back. Intravenous antibiotics would be indicated in selected patients if the patient is septic. And an urgent surgical consultation, as I mentioned earlier, should not be delayed while awaiting a diagnostic workup in such patients. Clinical review in cases without a surgical abdomen in the initial assessment, when the diagnosis is not clear, is an important step in managing these patients. So it may be even at the level of community management, community care, or even in the emergency department, or even an admitted patient. A review after a few hours, or in some cases, maybe even after 24 hours, is valuable in making further or clarifying the diagnosis in these patients. Now, this slide shows an algorithmic approach to manage a child with an acute surgical abdomen. And here at the top, where one suspects a surgical condition because the patient has some abdominal distension or focal tenderness and peritoneal signs. Now, some patients may be presenting in a bit of a catastrophic state. Child is prostrated, very sick appearing. The pain appears to be severe, continuous pain, and the vital signs may be unstable, sometimes the tachycardia or even evidence of poor perfusion. So this kind of clinical picture is often related to a perforated viscus with peritonitis, or if there is intra-abdominal hemorrhage, or if there is ischemic or infarcted bowel, such as in necrotizing enterocolitis, a volvulus, or a mesenteric infarction. And these are emergencies which will need good early resuscitation, effective resuscitation, and early surgical consultation is of absolute necessity, and diagnostic imaging may be required to make a diagnosis like a plain X-ray or even abdominal ultrasound and CT, but sometimes without much imaging such as ultrasound and CT, we might even have to take these patients in for an emergency laparotomy. Then we get another group of patients with abdominal distension, bilious or feculent vomiting, where we are suspecting intestinal obstruction. Now, here again, the causes in the neonates, one has to think of the possibility of volvulus in a previously well neonate, suddenly developing features of intestinal obstruction. In a slightly older infant, 2 months to about 2 years, we think of interception and an incarcerated inguinal hernia, as we mentioned earlier, and even sometimes Hirschsprung disease could present, even in the neonate, with features of intestinal obstruction. And in the older children, we have to think of adhesions that I mentioned earlier. So the main diagnostic workup, in addition to the clinical evaluation, would be plain X-rays of the abdomen, early surgical consult, and well, other imaging modalities depending on the clinical situation. Then we have probably the biggest group in the slightly older toddler and the older children, and that is where acute appendicitis is suspected, and the typical features: periumbilical pain shifting to the right lower quadrant, anorexia, nausea, fever, etc. And here we might have to do some added investigations. I will come to that aspect later and wouldn't waste any time at this point of time. Then, of course, there may be hepatobiliary disorders again, which may present with right upper quadrant or epigastric pain, maybe jaundice, hepatomegaly, nausea and vomiting, diseases such as acute pancreatitis, acute cholecystitis, cholangitis, or sometimes cholelithiasis. And in these instances, bloods such as amylase or lipase and lipase, liver function tests, and imaging studies, abdominal ultrasonography to start with, and it may have to be supplemented by MRCP or CT scans of the abdomen as required. Now, I direct your attention to acute appendicitis, which is the commonest cause of acute surgical abdomen in the school-going child. Although acute appendicitis could be reliably diagnosed clinically and supplemented by a full blood count or a CRP probably, this slide demonstrates that these typical features are not just confined to patients with acute appendicitis only. So in this study, about 270 appendicitis patients and 485 patients who had no appendicitis but presented with acute abdominal pain, we can see that the migration of abdominal pain was present in about half of patients with appendicitis, but such a phenomenon had also been observed in about a quarter, or 27% of patients who had no appendicitis. And even features like guarding and percussion tenderness were there in about 2/3 of patients with appendicitis, but in a significant percentage of patients without appendicitis, also these signs of so-called peritonitis or peritoneal irritation were there. Then right lower quadrant tenderness was there in about 2/3 of patients with appendicitis, wherein others, the tenderness was not exactly located in the right lower quadrant, confounding the picture. And in about half the patients with no appendicitis, also there was right lower quadrant tenderness. Rebound tenderness, again, similarly, about half of patients with appendicitis had it, and even a quarter of patients without appendicitis had rebound tenderness. Now, the basic laboratory studies of white blood cell count and the neutrophil leukocytosis was demonstrated. White blood count was elevated in 90% of patients with appendicitis, but it was also high in about half of patients without appendicitis. And 80% of these appendicitis patients had a neutrophil leukocytosis, but so did 40% of people without without appendicitis. So you see, diagnosis is just not as simple as it may appear sometimes in cases of appendicitis. Now, this slide shows the frequency of atypical findings in patients with appendicitis. And I want to highlight again, no migration of pain was seen in 50% of patients with appendicitis, right? 82% of patients with appendicitis had no temperature of more than 38 centigrades. Almost half, 47%, had no guarding. Maximal tenderness was not in the right lower quadrant in about 32%. And if we go into signs like Robsing sign, about 68% had no Robsing signs, and 51% had no rebound tenderness. So you see how the diagnosis can be sometimes difficult to make. So if one looks at the supplemental investigations that we do, the basic blood investigations, the white blood count and the absolute neutrophil count, you can see various studies show a sensitivity and specificity of wide variation for acute appendicitis, ranging from 70 to 80% sensitivity to 60 to 68%. So a rough sensitivity specificity for the white count. And the neutrophil leukocytosis also varying from 59 to 97% sensitivity and 51 to 90% specificity. So the predictive value of white blood cell count for diagnosing appendicitis is likely to be very different for all children evaluated in the emergency department versus those where the WBC is only obtained after a surgeon evaluates a child with right lower quadrant pain and feels that the likelihood for appendicitis is high. So in other words, a selective use or interpretation of these results in close collaboration or linkage, you take into account the clinical features also assessed by a surgeon. Similarly, with the C-reactive protein levels also, we see a wide range of sensitivity, 58 to 93%, and specificity, 28 to 82% in appendicitis. And so while CRP may be helpful in identifying patients who may have complicated disease and those who may benefit from additional cross-sectional imaging, its predictive value for appendicitis is limited as a sole diagnostic test. Furthermore, studies have not demonstrated any additional predictive value when obtaining a CRP in addition to a WBC count compared with obtaining a WBC count alone. So to improve the diagnostic accuracy, now there are validated prediction scores have been developed for appendicitis in adults and in children. And probably the two most common ones, common prediction scores are the pediatric appendicitis score and the Alvarado score, which are currently used using similar parameters. And although the original authors saw a very high correlation between these scores above the cutoff values that they devised, subsequent analysis by others have not shown that amount of sensitivity and specificity. And in this report by Snyder and his group, for the PAS, they reported a sensitivity of 82% and specificity of 65%. And for the Alvarado score, a sensitivity of 72% and a specificity of 81%. So although this combined approach of the clinical plus the bloods adds more weightage or accuracy to the diagnosis, still there is much that could be improved. So this is where to improve or increase the accuracy of diagnosis, imaging also now plays a role in acute appendicitis in children. So abdominal ultrasound scan, which is widely available, does not expose the child to radiation, but has the disadvantage of being observer or operator dependent, is relatively a good investigation. And one can see different studies. The sensitivity is quite variable. The lowest here being 0.44. And on the other hand, we have even a 0.9 or 90% sensitivity, which has been described in certain studies. So this may reflect individual practitioner-associated problems, maybe the cohort of patients that arrive, some may be coming more early and others may be later. We don't know. There may be variables. However, it has a fairly wide range of sensitivity. But specificity, on the other hand, seems to be pretty high on abdominal ultrasonography, ranging in the 90% range.
Dr. Malik, 5 minutes more.
Thank you, Jeepada. I'll finish off. CT scan in the diagnosis of appendicitis is an extremely sensitive and specific test, but the problem is there's a huge dose of radiation to the child, and it may not be as widely available all over the country and in places. So the limitation, although there is a place, the place is actually limited to special circumstances. MRI is now in the literature being described more and more, also very sensitive and specific. But the problems are, again, it's expensive, its availability, and it takes a longer time to do. And the child often has to be deeply sedated or even anesthetized sometimes to do it, because there is lack of cooperation and the time taken for the investigation. So basically, a computer tomography is not necessary in the routine evaluation of abdominal pain. And we must not do computer tomography for the evaluation of suspected appendicitis in children until after ultrasonography has been considered as an option. Other options to consider prior to CT scan may include an evaluation by a surgeon, which is very important, observation with serial examinations and review, which is very important at times, a repeat ultrasound scan even after a period of observation. And we might consider MRI, which has been shown to have similar diagnostic accuracy as CT in very special circumstances. Thank you very much.
Thank you, Dr. Malik Samarasinghe, for excellent presentation of the management of acute surgical emergency in pediatric age group. This is the time for question and answer. Any question from audience, please? Malik, shall I ask one question?
Certainly, Jeepada.
When a child, there's a common problem what we encounter is the child swallowing the lithium battery, and it comes as a surgical emergency. And how do we manage? Whether we observe, or is there any time limit to open and remove it?
Yes, that's a very interesting question, Mr. Chairman. Yeah, I think the first thing when the child presents to the clinician, important differentiation between actual ingestion and an aspiration, which I think is the first thing. So if there is any doubt about choking, coughing, etc., associated with this event of so-called swallowing, or if there are any respiratory distress or unilateral bronchi, or even a stridor, one has to strongly suspect a airway foreign body, and then it could be again quickly X-rays will probably confirm, and it has to be attended quickly, the airway issue, by relevant specialists who could do a bronchoscopic evaluation. On the other hand, if it is an ingestion of our little lithium battery, it is important for us to find out where this battery is. Now, and for that, sometimes clinical features might suggest that it's lodged in the esophagus, where swallowing difficulty may be there, but that is not always present. Actually, it is rare. So, an X-ray of the chest and abdomen will be of value, and that will demonstrate the position. Now, if the lithium battery is in the esophagus, usually it lodges either at the cricopharyngeus or at the lower esophagus, which are the narrower areas in the esophagus. And it is important that this battery is retrieved without delay, as prolonged contact, even hours of contact of a static battery, can cause erosion of the esophagus and even catastrophic fistulation or perforation. So esophageal foreign battery lodged in the esophagus needs to be taken out urgently. When it is in the stomach, also one might go in and take it out if the facilities of endoscopy are available. But often, if it has got into the stomach, by the time we evaluate, the foreign body has gone, the tiny battery has gone beyond the pylorus. So once it is a small bubble and it is moving, usually they are harmless, because it's the prolonged contact which is dangerous. So as long as it keeps moving in the gut, we just allow it, observe the child, and this will eventually or inevitably be passed out with the stool. So that is our approach to it.
Thank you, Malik. And there is one question on chat box. What's the incidence of COVID-related acute abdomen in LRH?
I am not able to give a incidence, a figure like that, but I can tell you that we have had patients with acute abdomen picture coming with COVID and mainly the MIS-C kind of illness, where there is abdominal pain, guarding, tenderness, rigidity, and usually this is more diffuse in the abdomen. And the giveaway is that these children are usually very sick and they are febrile. They usually have had a febrile illness before the onset of abdominal pain, and they look like the typical leptospirosis case with congested eyes, dry coated mouth, tachycardic with myalgia, and maybe you palpate their muscles in the back. There is tenderness, and so those are some of the giveaway signs that there is a systemic disease going on, and not just something like an acute appendicitis. I hope that answers the question.
Yeah, thank you. And one more question. Sometimes when a child presents with acute abdomen and we examine, we couldn't find clinically, and then sometimes we order ultrasound scan. The commonest report that we get is a mesenteric adenitis. In such a situation, do you manage or refer to pediatrician?
No, if it's just a brain simple mesenteric adenitis and we don't suspect anything sinister medically, we usually don't just keep transferring the patient around. In our setting where it's a pediatric surgical unit, we do manage in our wards. But if we think there is something else going on other than a pure and simple mesenteric adenitis, for example, sometimes dengue fever can present with features that simulate appendicitis. And if we so suspect, based on the history, the low platelet counts, and sometimes the ultrasound may show a little bit of effusion, pleural effusions also, then yes, we definitely do get our pediatric colleagues into the management of those patients.
Thank you, Malik Samarasinghe. And in the absence of other questions, we will move on to the next presentation, Malik.
Thank you very much, Deeparam.
Next presentation is on management of surgical emergency by Professor Nabil Pereira. He's a senior consultant urological surgeon, Department of Urology and Renal Transplantation Unit, the National Hospital of Sri Lanka, Colombo. He's a professor in urology, postgraduate Institute of Medicine and of University of Colombo. He will present on the surgical management, genitourinary surgical management. Professor Nabil Pereira, over to you.
Can you all hear me?
Yeah.
Okay, right. First of all, I must thank the organizing committee and the chairman for giving me this opportunity to speak on this quite common gamut of diseases and the current concept in management of urological emergencies. Urological emergencies, basically, I would discuss it under two topics as fast as I could. That is non-traumatic emergencies and the traumatic emergencies. And basic idea is to save life, save organ, and then save ultimately the function. So under non-traumatic emergencies, I'll be summarizing the current management of acute obstruction to the urinary tract. And especially when it is complicated with infection, it's going to be even more of a problem. And then acute scrotum, very shortly, because it's a true emergency when it comes to it. And then the compartment syndrome, the penis, that is priapism, and severe exsanguinating hematuria we come across off and on. When it comes to upper tract obstruction, the commonest cause is the urinary tract, the upper urinary tract obstruction with urinary calculi. And patient will present with one of the worst pains a man or a woman can experience, that is urinary colic. And then it is generally a clinical diagnosis, but you have to be sure that you exclude the other sinister causes like leaking aortic aneurysm in an older person. So anybody without a history and a history of hypertension or aortic aneurysm, do not diagnose renal colic, though it is unilateral pain. So always the screening investigation will be ultrasound scan, and that will show us if there is any upper tract obstruction like hydronephrosis. But remember that the uterine stone can obstruct the upper tract, and then there can be acute renal shutdown, and there won't be any time to develop hydronephrosis. So absence of hydronephrosis doesn't mean that there is no obstruction. And non-contrast CT of KUB has become the gold standard in detecting stones, because about 60% of stones in urinary colic will be missed in X-ray KUB, because either they are too small or they are superimposed by the bony prominences. And once it is diagnosed, once the non-contrast CT is done and there is suggestion of ureteric calculi causing this ureteric colic, and nowadays the first line treatment will be starting, apart from the pain control, starting tamsulosin or alpha blockers, which was not there earlier a few years back, but it has become standard treatment for any stone less than 6 millimeters. But what they have now recently shown is that 4 millimeter or less, the stones, you don't need any of this medical expulsion therapy, because the spontaneous expulsion and tamsulosin expulsion, the rates are same. Then you have to be cautious about giving NSAIDs to these people. And then when you are giving alpha blockers, always explain the possibility of postural hypertension and then retrograde ejaculation to the younger crowd, because they sometimes get scared and stop the medication. And infection will compound the picture. If there is upper tract obstruction and infection, the renal destruction, parenchymal destruction starts very fast, very early, and within 6 hours. If you don't attend to it with antibiotics and deobstructing or get rid of the obstruction you will find that the permanent renal damage can ensue. And the renal decompression, especially if you have fever, chills, rigors, hydronephrosis, signs of obstruction and infection, the current management will be the immediate decompression by using a J-stent, cystoscopic guided J-stent, which in a ill patient will be a bit of a challenge, putting him under anesthesia, but much easier and faster method will be percutaneous nephrostomy, or what we call PERC, done by interventional radiologist under ultrasound guidance. So if there is neutrophilia and fever and high CRPs and signs of infection, immediate PERC and decompression is important, will be followed by definitive management at a later stage when the patient is much stable. And the commonest method of management will be ureteroscopic intervention, either rigid or flexible ureteroscope. As you can see here, the stone can be fragmented and taken out, and the stent will be removed after a couple of weeks.
Proper, there's volume not adequate seems. Can you use this? Volume not adequate.
Okay,
some
okay.
participants have.
Right. Just a minute. Small stop. Just give me a second. Yeah. They couldn't hear. Maybe I'll just hold it. Yeah. Hello, can you hear me now?
Yeah. Now it's good.
Yeah. It's much better? Yeah, okay.
Yeah, it's better.
Right. Then when it comes to lower urinary tract obstruction, there are 4 main clinical types, out of which chronic low pressure retention, which is not an emergency and will not be dealt in this part of the discussion. And acute painful retention is the commonest presentation to a A&E department. And there is acute on chronic painless retention, which is painless. So still it is acute retention on a patient who has been chronically retained for a long period. And chronic high pressure retention is a special entity, and it is a dangerous entity where the retention is associated with upper tract dilatation and hypertension and renal impairment, and it needs prompt attention. And generally, the principle is not to treat these patients with drug therapy. Common causes I have listed here, and it's a common knowledge. Prostatic enlargement and the obstruction is the commonest, followed by in younger people, always suspect urethral strictures, and gynecological patients, retrograde uterus in reproductive age, females, and neurological, acute neurological retention, secondary to lumbar disc prolapse, so vertebral metastasis getting swollen up, and this is actually neurological emergency as well. And the investigations will reveal the presence of the enlarged prostate, and in the ultrasound is the center point of diagnosis, and it will dissect and it will let us know whether there is upper tract dilatation, which says that this patient is going to end up in more or less surgical treatment rather than medical treatment. And it will also give the prostate volume and pre-void volume, which is a large bladder. We know that is acute on chronic retention, and the bladder wall thickness, and the new concept of this intravesical prostatic protrusion, the median lobe protrusion, if it is over 1 centimeter into the bladder, very likely that he will fail drug treatment or medical treatment and will end up in surgery. And relief of obstruction, initially it will be urethral catheterization, and this is a basic MBBS skill. And we go down from starting from 16 French catheter up to about 10 French catheter, and if it is also not accommodated, then you have to move on to do a suprapubic cystostomy. An important point in relieving large volume bladders with chronic retention, there is this post-decompression phenomenon called post-obstructive diuresis and post-obstructive hematuria. And diuresis can be sometimes pathological and will continue up to about 2 days to 7 days and the patient will produce about 10 to 14 liters of a day. And if you have discharged the patient, he will go home and collapse because he can never keep up with this urine loss. So you have to be careful. If you have emptied a large amount of urine over 800 cc or so, admit the patient and observe for severe post-obstructive dialysis. And hematuria is also a problem. And by catheter clamping and unclamping, intermittent clamping and unclamping, which is a very old and obsolete concept, you will not prevent any of these complications. So there's no point trying that. It is just admit and observe. Definitive treatment will be followed. And nowadays, the first episode of acute retention is not treated with surgery like good old days. If it's the first episode of acute retention and there's no upper tract dilatation, then the first step of management will be alpha blocker trial. You give tamsulosin, a selective alpha blocker. For 3 days, you start it, and then after 3 days, you remove the catheter. But in our part of the world, we leave the catheter for 7 to 10 days for the prostatic edema and the superadded infection to settle. Once you give the trial, and if he passes it, and if he passes in urine, then of course you continue him on tablets. Otherwise, the patient will end up in the definitive treatment. And you have to make sure that the patient doesn't have hydronephrosis or chronic high pressure retention before you consider alpha blocker trial. And strictures will have specific treatment, endoscopic ureterotomy, which will end up in uretroplasty. Move on to massive hematuria, which is something alarming, which we come across off and on in the casualty department, and the GU malignancies. Bladder cancer and renal cancer sometimes can lead to these massive clot colics and hematuria. And the BPH, large prostates, they have the dilated veins over the prostate surface, and the patient strains, and one of these big veins can rupture and will lead to massive hematuria and clot retention. And often after discharging the patients after TURP, they present after 5 to 7 days with secondary bleeding, which also can be alarming. And then radiation cystitis after pelvic irradiation, which is given for various causes like gynecological causes, or sometimes for occasionally bladder cancer or prostate cancer. Radiation cystitis can lead to recurrent massive bouts of hematuria, which is very bothersome. And hemorrhagic cystitis and chemical cystitis, some people have to keep in mind. People who are on chemotherapy, it's cyclophosphamide, it's a known complication. And chemical cystitis, when the ketamine is used for recreational purposes, which is not quite common in this part of the world, but it is a common cause in, anybody coming with the clot retention and obstruction, the first step will be resuscitation if his vital parameters have gone down, and then clot evacuation. Using a bladder syringe and the catheter, you can try that, and if the clots are small and they are floating, then you might escape with that. And then following that, you have to put a 3-way catheter and then continue irrigation of the bladder until the effluent is clear. Then the bladder washout fails, then of course you have to look for specialist involvement, and cystoscopic clot evacuation will be the final answer, because as long as the clot is there, there will be continuous bleeding, because there is a local DIC type of reaction. And finally, if it continues, the bleeding continues, especially hemorrhagic cystitis or chemical cystitis, and then you can't find the exact place of bleeding, and you know it is a bladder, then of course we have to go to the interventional radiologist, who will do the internal iliac ligation, internal iliac artery embolization, which spares us of this old practice of tying the internal iliac artery to stop pelvic or bladder bleeding in good old days. And if it is not being done after all these episodes, CT urography and cystoscopy is a must for all these patients. And then the acute painful scrotum. I think this is one very important emergencies comes to the pediatric and sometimes surgical emergency. And testicular torsion, it should be considered in a child between, say, 5 and 18, adolescent, until proven otherwise. You take a all testicular pains as testicular torsion, because there is disastrous misdiagnosis of acute epidermolysis, which can get you can get confused with testicular torsion. And these basic clinical features like loss of cremasteric reflex and swollen and transversely lying testes, these have been taught over and over again, but still we see these cases. And with these signs, the clinical diagnosis should be made, and time should not be wasted, because after 6 hours of twisting, if there is ischemia, testicular ischemia, there can be permanent damage or gangrene of the testicle. And when we are in doubt, the best help is to do a color Doppler, which will show the blood supply, blood flow to the testes, and in infective causes, the blood flow will be retained, but this is also not 100%, we must remember. And then timely surgical exploration with detorsion or occipectomy, if it is gangrenous like this, or and then bilateral fixation. If it regains after detorting, if it regains its viability, you fix that testis plus the opposite testis as a routine. Priapism is another problem I think we come across, and this is described as the persistent state of penile erection and continuous beyond its necessity and without sometimes sexual stimulation. Over 48 hours, if you allow it to go on, it can have disastrous consequences like permanent erectile dysfunction, especially in young people. Generally, nowadays, we classify these into low flow and high flow, ischemic and non-ischemic, which is the common category is low flow, where there are various reasons because the increased use of intracavernosal injections like papaverine or prostaglandin and PD inhibitors like sildenafil, they all have this complication, and then antipsychotic drugs, and mostly it is idiopathic. But then occasionally, when you investigate, you find that these patients will have some blood dysplasia, so that should be in your list of investigation. And spinal cord trauma due to vasodilatation can also lead to this low flow ischemic priapism, where the blood supply to the penis is cut down and the penis is full of deoxygenated venous blood. High flow is a rare presentation where there is penile trauma and there is a arteriocavernous shunt, and the penis is rigid but not that rigid as ischemic, and it is well arterialized, so that this will not lead to permanent erectile dysfunction, and the treatment will be selective embolization. And when it comes to priapism management, there's a whole gamut of treatment, and if it presents early enough, we first aspirate the cavernosa and then inject vasoconstrictors like phenylephrine, adrenaline, metraminol, and early cases respond to this quite well. But if it fails and there is a delay, and then surgical intervention with various types of cavernospongiosal shunts are being tried. I'm not going to go into details, but there are various techniques where you connect the glans penis or the spongiosum to the cavernosum. Because the point is that spongiosum never gets involved in priapism. It's only the cavernosal tubes. And therapeutic embolization is for high flow arteriocavernosal shunts. And then nowadays there is a trend to, for late cases, there's a trend to go ahead with penile prosthesis straight away, because what they feel is that once the cavernosa is ischemic, there's no point doing any of these shunts, just straight away go for a penile prosthesis. And paraphimosis, I'm not going to go into details because of the time constraints. And it's a complication of, as we all know, complication of phimosis, unattended phimosis. And after catheterization, all medical officers should know that they should reduce the prepuce. Otherwise, in older people, you can end up in this dreaded situation. And generally, we try to reduce it at the beginning, and then if it fails, you either do a dorsal slit, cut it there, or do a femoral circumcision. Let us move on to the last few minutes, traumatic injuries, the current situation of management. And out of that, we go down from the kidney to the urethra. And the mechanism of injury is quite well known and blunt, or it can be blunt or penetrating. any blunt trauma to the lower chest or loin area, there should be a high suspicion of renal injury. And then motor vehicle accidents are the commonest comes to it. And then penetrating injuries, as you can see in this slide, it can be stabs or penetrating impalements like this. And iatrogenic trauma is becoming much more commoner because we are in the field doing percutaneous renal surgery and biopsies and stone surgery, and that has become very common now. And when it comes to imaging, the plain X-ray, if it is being sent to you from the periphery when you get the injury, it might give some telltale marks of kidney injury. Because if you have fractured transverse processes, that is a sign of high force, bending force or high force on that renal area. And the fast scan has to be done to make sure that there are no other intraperitoneal bleeding. And computer tomography has become the gold standard of detecting renal injury nowadays, triphasic CT angiography. And then that will give some idea about the renal and ureteric injuries as well. Occasionally, we do intravenous pyelography on table, one-shot intravenous pyelography, if we don't have a CT to go by. And direct angiography is nowadays not done on diagnostic purposes, but is only for therapeutic purposes we do it. And indication for surgery includes important thing is that you have to decide. As surgeons, we always face this problem of deciding when to explore. So fortunately, most of the time, the Derotas fascia, nature-given protector of the kidney, when the kidney gets ruptured even into pieces, grade 3 or 4 or 5, the bleeding will stop after some time. And then if the patient is going into hypovolemic shock, always look for some other cause. Patient is having generalized abdominal pain or signs of acute abdomen, always look for some other cause. Don't decide to open the renal hematoma to cure that. And only time is that if there's a massive uncontrolled hematuria or pulsatile expanding hematoma, and there are signs of destabilization of the patient without any other reason. So you have to explore the hematoma. And if you explore the hematoma, most of the time you will end up in nephrectomy. So because of that, nowadays, the first line treatment in all guidelines is to call the interventional radiologist to embolize the bleeding artery. And that way you can prevent nephrectomy and might be able to preserve part of the kidney as well. Ureteric trauma is quite rare in civilian injuries, but iatrogenic trauma, as we all know, the urologist and gynecologists play a big role. And a missed ureteric injury, if you detect it on the table, I think is at the best time to repair it, but otherwise it can lead to leaking of urine, leading to urosepsis and urinary fistulae, and ultimately ureteric stenosis and obstruction. So that first line of treatment will be decompression of the upper tract if there's a ureteric injury, and then later on go for various types of definitive surgeries to bridge the gap or reimplant the ureter at a later date. Last couple of slides, the bladder trauma. The external trauma is quite common, and it is either due to the full bladder. When there is a direct blow from outside, you can get either intraperitoneal rupture or extraperitoneal rupture. And after pelvic fracture injuries, this is quite common because bony spicules can injure the bladder. And the symptoms can be very subtle, and there has to be very high degree of suspicion, because an unemptying bladder after putting a catheter will raise the suspicion of a bladder rupture, because half of the urine will be inside the bladder, half will be in the peritoneal cavity. And especially if the patient has spinal cord injuries, you have to be very suspicious because they will not complain much about abdominal pain. And when it comes to diagnosis, CT contrast histography will give you the clue. And then treatment-wise, if you take all bladder ruptures should be opened and sutured, and there are various techniques of doing that, but that is a must. So bladder rupture cannot be managed conservatively. Coming to urethral trauma, finally, it can be either anterior urethra, which is outside the body, and straddle injuries, falling astride injuries, and urological instrumentation or any kind of instrumentation can destroy that. And posterior urethra is commonly destroyed or ruptured secondary to pelvic fractures and due to motor vehicle. Pathognomonic sign I have shown here. In anterior urethral rupture, there will be peritoneal hematoma, and all urethral ruptures will have blood in the meatus. And basically, the management-wise, important thing lies still, does not change, that if you suspect urethral injury, if you diagnose it with a urethrography in the accident and emergency, or if you suspect clinically, don't go for catheterization. Unless you have an expert to do that with a small catheter, always go for suprapubic cystostomy and diversion, and refer to a specialized center for delayed urethroplasty. By trying to catheterize, you will make the matters worse. The last slide will be on genital trauma, and SIPA injuries of children is quite commonly encountered, and then penile fracture due to various sort of sexual acts, and then degloving injuries and emasculation of the penis is here, you can see that. And all these injuries, the basic principle is to debride, do an anatomical repair, and try to get the skin cover. So you need the specialized attention at an early stage to prevent consequences. And the testes can be ruptured, or can be a hematoma, or sometimes it can be avulsed. The penis, if it is severed, if it is brought at an early stage, penile regrafting is possible, but generally it will end up in a penectomy. And then scrotal restoration and degloving injuries, you have to reroute the testes and try to get the skin cover as much as you can. Thank you very much for your patience listening.
Thank you, Prof. Neville Pereira, for excellent presentation on genitourological emergency covering wide range of emergencies. Thank you very much. Is there any questions from the participants, please? So, can I ask one question, sir?
Sure, yes.
So, the general surgeons who are working in the periphery come across with some villages. They come and complain that while they are taking bath in the lake or the river, they complain that something has gone into the urethra and they present with a severe hematuria. That is probably due to some leech goes inside. So in that situation, how do we manage?
Yeah, that's an interesting situation. I think if it is an elderly person, especially over the age of 40, best thing is not to believe that story, because that will be a distractor. And if he comes and says there's bleeding by urethra, and if there's hematuria after their bath in the river, I think you have to investigate him on the same lines as case of unknown hematuria or bleeding PU. Because urethra is all the time is closed, because urethral muscles keep it closed and coapted, and rarely you can get leeches and various insects, various foreign bodies entering the urethra. But then this story of bathing and having hematuria, the most important thing is that you should not believe that straight away, and you must go for cystoscopy and basic radiological diagnosis.
Thank you.
There's a question here, bit more about trial without a catheter for treatment of BPH. I'll spend a couple of minutes on that.
Yeah.
Am I allowed to go on?
Yeah. Yes,
yeah.
Sir.
So basically, catheter, the trial without catheter has a meaning to it. And catheter removal is not similar to catheter trial without catheter. TALK is a standard shortened form for that. What that means is that when you come with the first retention of urine, it is not an indication for surgery. So what you do is you start the patient, if you are suspecting BPH, you start with alpha blockers like tamsulosin or silodosin, and then this drug will take about 24 hours to 72 hours to work, to relax the bladder neck. So you put them on these drugs and then discharge the patient if there's no other indication to keep him, and then remove the catheter, ideally, after filling the bladder with 300 cc of saline. But this can be done only in a specialized setup. Then you immediately you will know whether the patient is passing urine or not. But by any chance, if that is not possible, you just ask them to remove the catheter in the morning at 8 o'clock, because sometimes they remove it in the late evening and go back to retention late night. So morning, and wait till about 2 o'clock in the evening. And if they are not passing urine well, recatheterize and consider surgical intervention. So if absolute contraindication for catheter trial are upper tract dilatation, hydronephrosis, and if you are suspecting a chronic high pressure retention where there is hydronephrosis and renal impairment.
Thank you. Now all three speakers are online. Is there any questions from participants, please? So there is a question, if there is a urethral injury due to trauma to pelvis and there is a blood at urethra meatus, there is a suprapubic distension as well. What must be done next? There's a one question from an anonymous attendee.
Yes, that's a good question. That shows that the bony spicules following these pelvic fractures, trauma to the pelvic fractures, has injured the bladder base plus the posterior urethra. As you know, the posterior urethra is the prostatic and membranous urethra, and the bony spicules after pelvic fracture has no boundaries, so that it can injure the bladder plus the posterior urethra. So you have to think of that. And if after having a suprapubic catheter, if there is a suprapubic mass, that means there is extravasation. So extraperitoneal extravasation, that is what we call non-emptying bladder. So having blood in the meatus means there is posterior injury as well. So again, the treatment will be to do a contrast histography to make sure that there is the bladder injury plus urethral injury through the catheter, suprapubic catheter, and then if there's bladder injury, to go and repair it. But if there's urethral injury alone, you just leave the catheter there, and after 3 months come back and assess the stricture and do a urethroplasty.
Thank you. In the absence of any other questions, shall we conclude this session on management of surgical emergency? Thank you for all three speakers and the organizing committee for arranging this very fruitful discussion on the management of surgical emergencies. Thank you, sir.
Thank you, Dr. Jipra.